Now, it's important to know the predictors of no reflow, because if you want to prevent no reflow, then you need to know the predictors and how you can improve them. Now, there are the predictors of no reflow can be divided into two groups. There could be patient-specific features or procedure-related features. Patient-specific features are age over 65, female, hypertension, smoking, dyslipidemia, diabetes, renal failure, rheumatoid arthritis or other inflammatory process, atrial fibrillation. All this would increase the risk. On the other hand, procedure-related factors we know: increase in thrombotic load, delayed presentation, high pressure inflations, use of debulking devices, that would increase the chances of no reflow. Now, coming to the prevention of no reflow, I will divide it into three categories: generally accepted, controversial, and experimental. Now, what are these generally accepted? Now, we know that shortened door-to-balloon time would reduce the incidence of no reflow. And that is because more prolonged ischemia is associated with more microcirculatory damage and therefore development of no reflow phenomena. And also we know like direct stenting in acute MI would cause less embolization of the debris, and that would also result in reduced no reflow. And if you avoid high pressure post-dilatation with balloon in patients who are at high risk of no reflow, then it's very obvious like there would be less embolization and less reflow, chances of reflow. And if you're using rota, say, then you always try to use shorter burr runs and lower speeds and avoid decelerations. If you really, especially in high risk patients who are at high risk of no reflow. And in case of saphenous venous grafting PCI, again, which is associated with high incidence of no reflow, it's best to use an embolic protection device. And there's been some evidence to say that pre-treatment with intracoronary vasodilators could be useful in such a situation. Now, also we know, like there's some other things, factors, like if you have cardiovascular risk factors, and if these are very optimally controlled when the patient is going to have a PCI, then it reduces chances of no reflow. And statin pre-treatment has some evidence, and it showed that although it did improve the coronary flow after primary PCI, it actually didn't reduce the MACE. Now, there's some controversial issues. For example, what about intracoronary vasodilators to prevent slow flow, not infringement? Now, the Amistad 1 and 2 has showed that the clinical outcomes in patients undergoing primary PCI were not significantly improved with adenosine, although the infarct size is reduced. And reflowstomy showed that neither the infarct size nor the microvascular obstruction was reduced by intravenous nitroprusside or adenosine. Sorry, not intravenous, I would say intracoronary. Now, it's a very interesting topic is that I would like to put in 2B3 inhibitors. Okay, so the On-Time 2 study, which was done quite some time ago, is a study which showed that the pre-hospital initiation of bolus tirofiban could result in ST segment resolution and improvement in clinical outcome after primary PCI. But note that such trials were done before actually the potent P2Y2 inhibitors like ticagrelor and prasugrel was available. But the contemporary trials have not demonstrated such a useful effect. However, patients undergoing primary PCI may benefit from it, especially if there is an established no reflow, large thrombus burden, or for bailout cases. Now, regarding thrombus aspiration, a meta-analysis has failed to show the long-term benefit. On the other hand, manipulating the occluded area with balloons and stents often results in distal embolization of the thrombus, which may contribute to development of no reflow. So routine aspiration should be avoided and should be limited to the presence of angiography visible thrombus only. And lastly, the experimental ones, and these are the ones like intracoronary fibrinolysis, ischemic preconditioning or conditioning, therapeutic hypothermia, and hyperoxemic reperfusion. I wouldn't discuss these because these have not been shown really to help. Thank you very much.